Over to
Thank
you.
you, sir.
And Avneet will be ready and he will be answering your this thing.
1 minute. Yeah.
Yeah, we can see. Carry on.
Yes, sir.
Carry on.
Well, good evening, friends. Do we really need a debate? It's a new tool on the horizon. Rather, it has stepped in. And well, the audience poll has already established my fact. I don't think I need to debate, but yes, I am there. I am there for that it is impossible to manage AMD without OCTA. Well, to manage neovascular AMD, we have these 4 diagnostic tools which not only help you in diagnosing, but help you in monitoring the diseases as well as prognosticating the disease. Fundus fluorescein angiograph is an age-old and has been a gold standard in the diagnosis of all retinal vascular diseases. Yes, we can diagnose only classic CNVMs and RAP lesions with angio, and that constitute only 46% of CNVM. In fact, 56.6% is unseen as seen from this particular evaluation. Another study which shows a detection rate of 30% with accuracy of only 67.44%. So how much are we missing if you do FFA alone? Yes, Dr. Amnindra will stress upon one particular point, that is leak. Is leakage only the sign of activity which we do not see on an OCTA? Does it really decide the initiation and monitoring of the disease? Does it really change your treatment or the molecule which you choose for the treatment? Why are studies not based on fluid, but based on rather than on leakage, but based only on visual acuity, fluid, and OCT, and not on leakage? Well, you need to introspect. Importantly, leakage also falsely increases the size of the lesion by 25%. Now coming to the another tool which helps you, that is ICG. Well, yes, 52.4% is the detection rate, and the positive predictive value as well as negative predictive value is quite high with this particular investigation. But remember, this particular detection rate is not with the routine optical fundus cameras which each one of us has in the periphery. It is with only the SLO based HRTs. And remember, there are only 140 HRA based ICG based cameras in our country. So can we really pick up the lesions with this accuracy? Well, need to think about it. Now, this is a study which shows OCTA versus dye angiography in age-related macular degeneration, and the sensitivity and specificity of OCTA is well, you can pick up from this 88%, 90%. Another study, this is a review article published in BJO in 2019, where all the studies regarding OCTAs in neovascular AMD has been compared. And you can see the sensitivity of the OCTA is from 50 to 86%, while specificity is as high as 67 to almost 100%. And if you combine OCTA with an OCT, which is an inbuilt feature of any OCTA machine, well, the sensitivity and the specificity almost reaches a to 100% level. So what does role OCTA offer to us? In the case of a wet AMD, well, you can pick up a type 1, type 2 CNVM very easily, and even type 3 lesions, though sometimes you can miss it out. And remember, the OCTA features are concordant with those seen on FFA as well as ICGA. Importantly, OCTA has a sensitivity of more than 80% and specificity of more than 90%. Well, you can monitor the AMD progression with OCTA. You can see a baseline over there, a CNVM over here after 1 month, and then you see after 4 months, and then at 6 months. In fact, OCTA picked up the CNVM before it became clinically symptomatic. So this is the advantage of OCTA. Now, if you're treating a disease, look at when you are looking at a follow-up. What do you see on an angiogram? Nothing much. But well, on an OCTA, you can see the beauty of the regression of the particular CNVM membrane. So really, do we need FFA for follow-up? Never. Now coming to etiological causes of CNVM. CNVM has certain typical characteristics associated with other ocular morbidities. For example, in myopes, the membrane is usually irregular in shape with poorly defined margin without a visible core. In a Best disease, you have associated with CNVM FAZ abnormalities of superficial and deep layer abnormalities. So if you see such features, well, you can differentiate it from a more, yes, why not? Morphological characterization is possible of the microvasculature of the CNVM as well as adjacent structure because of the higher resolution capacity. And well, in an active CNVM, in an occult CNVM, you can see a loop-like structure, you can see a blooming tree appearance or a sea-fan pattern. And even in a scarred pattern, well, you see a ghost tree and you know you need to stop the treatment. Pre-treatment OCTA and post-treatment. So what do you see on a post-injection changes? There is a loosening of dense vascular network which is seen in active. There is a regression of peripheral capillary tuft with persistence of central tract and decrease in CNVM area as well as blood flow. All this can be beautifully monitored and actually you can convince yourself about the changes which are happening. Now coming to the size of lesions. Size of lesion is 25% smaller on OCTA compared to FFA. And this means if we use OCTA lesions, OCTA as a reference marker while treating it with a focal laser for an extrafoveal CNVM or a PDT, your spot size can be relatively smaller. And if smaller spot size, it means the collateral damage to the adjacent retina is going to be less. Now, these are some of the examples. Sorry. You see an angio, you see some hyperfluorescence over here, ICG again, not much contributory, but you see an OCT OCTA over here, you can well see a very nice vascular network. This is a collage of 4 cases which shows how the other modalities missed but was picked up on an OCTA. This is a case of a chronic CSR. Again, you can see an ink block leak. ICGA cannot adding much to our insight. But when you see an OCTA, you could pick up a CNVM over here. And when the treatment modality was changed, you moved to anti-VEGF, you started seeing the resolution of this in chronic CSR, which was not amenable to other modalities of treatment. Well, this is a case of a PCV where you can see on an ICG and OCTA where you can, OCT where you see a double hump as well as a double layer sign, and OCTA showing beautifully the BVN over there. So really, do we need an invasive investigation like ICG? Remember, age-related macular degeneration is happening because of the aging. With aging, other organs also vital organs are also affected. Now to quote few, in kidney, the GFR keeps on decreasing with age without even having a kidney disease. And if you see the association of kidney disease with AMD, it is almost 18%. LFT similarly gets affected with age, and the association of age-related macular degeneration with coronary or chronic vascular disease is as high as 40%. So imagine the risk which you are putting this patient when you are using these modalities of treatment. Leave aside the aging part of it, but look at the severe adverse events like bronchospasm and laryngeal edema, which is close to 0.5%. That means 5 in 1,000 patients can have a serious adverse event. And look at ICGA, almost similar. It means 5 in 10,000 can have serious adverse event. So remember, safety isn't expensive, it is priceless. And the first thing which we learned when we take a Hippocrates oath is that the hospital or the doctor should do the sick no harm. Equally important is the era in which we are placed. This is against Violence Against Doctor, Consumer Protection Act. So taking the safety, taking care of me too, safety of me too is equally important. And look at this socio-economic profile of our country where majority, more than 30% of the people cannot even afford a fridge or a phone in our country. And if you're going to do such costly investigations like FFA, ICG on and off, do you think it is possible? Why? Basically because CNVM is not a finite disease. It needs a long-term follow-up, and many times these investigations have to be repeated. Besides, we also have wealth of evidence in the form of these tabular charts where I'm running through it, which is equally convincing. I know my worthy debater is going to find out and talk about the limitations of OCTA like segmentation difficulties, poor fixation, flow dependency. But tell me, a person who is flawless or perfect, no one is flawless or perfect. This is an evolving strategy. He would even talk about leakage, which I've already negated, and about the area of scan. But today, now the newer machines have a bigger areas of scan. And these are the advantages of OCTA, which I will just run through, which is repeatable, reproducible, and not much cost involved in all this. Well, you can also see etiological differentiation, morphological characterization of CNV, and you can keep on repeatedly repeat it and reproducible. So well said by Einstein, if you do what you always do, you get what you always got. So remember, though Mirage was in our fleet and did wonderful job, it was a trusted lieutenant for our Indian armies, Indian Air Force. But today is the era of Rafale, that is OCTA. So dear friend, we need to get over our fixation. So now we need to learn the beauty of this machine by learning about this machine. And how do you learn? First is to unlearn, and that is get over our fixation over leakage. Unless we see leakage, we are not comfortable. So once we unlearn this, then we will be able to explore the beauty of this new instrumentation. And yes, friend, remember, if you unlearn and learn this technology, well, you will have a crown over your head, which even your peers as well as your patients will be proud to see on your head. Thank you.
Wonderful, wonderful, I should say, Prashant.
Thank you,
In
sir.
fact, in case I was in place of Nindra, I would have backed out, honestly speaking, because